I'm Dr. Alexandra Peters, and it's my great pleasure to introduce Professor Chuck Gerba for this Weber teleclass. Professor Gerba is a professor of environmental microbiology in the Department of Environmental Science, Environmental Health, and Epidemiology and Biostatistics at the University of Arizona. He has been an author on more than 700 articles, including several books in environmental microbiology. He's a fellow of the American Association for the Advancement of Science and the American Academy of Microbiology. He conducts research on infectious disease transmission by food, water, and built environments, applications of quantitative microbial risk assessment to quantify interventions to reduce disease transmission, and assessment of novel disinfectants against emerging pathogens. And so it's with, yeah, great pleasure, and I very much look forward to your talk.
Well, thank you, Alexandra, for that introduction. I thank you for giving me a chance to talk about it today. I'm really going to be talking a lot about some of our recent research on the dynamics of how microbes move in the built environment that are related to potential health risks. I'm going to cover, let me see if I get the next slide here. Oh, okay. Oh, yeah, it takes a minute here. I kind of give it an outline. What I want to talk about the importance of fomites in disease transmission. That's really what the focus is here. But to look at the dynamics of how resuspension of microbes into the air from surfaces also plays a significant role, not only in the transmission versus the touch of the surface, but also inhalation of the organisms, even though they may not be on a surface, they can be resuspended by human activities, which I want to discuss, and then give examples of rapid movement of virus tracers in the built environment. We've done a number of studies where we place non-human infectious viruses on surfaces and watch how they spread through a surface as human activity takes place in a building. And then risk assessment of fomite transmission. What we try to do with this data and looking at movement of viruses in the built environment is what is the real risk of it? Yeah, we can show they move around in that, but what's the infection risk? What's the probability of somebody getting infected? And a little bit, I'll talk about mobile devices. And just to give you a background again, the role of fomites are inanimate surfaces generally that can be involved in the transmission of infectious diseases. And the dynamics of it oftentimes is sneezing, coughing, contaminated hands, some use of the restroom, and then you're contaminating surfaces in the work, phones, computers, desktops, clothing. Are all involved in that. And of course, the transmission occurs when these surfaces are retouched again by another individual who's susceptible to becoming infected. Now, disease transmission through hand contact, again, to give you a little bit of a background, people have done studies on hand contact, and we have also done in our studies looking at how often people will bring their fingers to the nose, mouth, and face. A child does it at the highest frequency, about 3 times a minute. And every time an adult, by the way, will bring their fingers to their face about every 3 or 4 minutes. You do it subconsciously without realizing, and it depends upon the activity going on in the environment. Interesting, we've done studies with people in churches and religious events, and they tend to touch their face less than they do when they're by themselves. But other activities in the environment will play a role in that. But you're always touching objects all the time. We've monitored people and done diagrams, and others have, on how often you touch, obviously. But if you're working in an environment, particularly in an environment where you're moving around all the time as part of it, you may touch as many as 30 objects in 30 seconds. You can believe how rapidly objects may be tested. So you're interacting with your environment all the time. And so it's an important thing to recognize. Now, just to give you an idea, I have this diagram here of what's going on in your environment all the time and your activities on it. Aerosols are being generated all the time. Just to give you an idea, you have vents entering air, for example, toilet flushing, showers. These actually impact surfaces, all the movement, and maybe sources of organisms like toilet flushing, mopping. You can see here, mopping actually, particularly with wet mops, is a good way to spread organisms around. But also vacuum cleaning, which I'm going to talk about a little bit, Vents again, and plants actually can be a source when people disturb those. They put my organisms into the air all the time. Insects move things around too as they're walking around in a household. Pets will do it too. But all these human activities create situations where microbes can be resuspended from the air when they're already on a surface. But how important is that? And that's what I really want to go into, is trying to look at the importance of all this activity and microbial movement. One of my colleagues once said, "Whatever on the floor tells you what's in the air that you're breathing all the time." Just to give it a little bit more perspective here of everything, to give a focus on this and how to think about it, we look at an infective individual. It can be both respiratory, but also can be, fecal contamination of surfaces from contaminated hands, or touching other surfaces and moving organisms from one surface to another. When people sneeze, they put large droplet nuclei, which settle very quickly to surfaces, but aerosolized ones can spend hours in the air, as we'll talk about a little bit. And all of these can be transferred by touching surfaces or inhalation by other individuals, indirect contact, and all of these can be activities which result in the contamination of an environment that we're looking at. Our origin of indoor environmental bioaerosols, I went through that a little bit, but there's some other here is to realize, like house dust, which I'm going to emphasize in this, plays a role with the accumulation of microorganisms. Actually, some replication of some organisms, like fungi particularly, can occur in house dust or dust from other surfaces, and can be sources of potential aerosols. So fungi shouldn't be overlooked too, because they actually grow on surfaces, even in really dry environments. And then ventilation, air conditioning creates the movement of air. It can be a source of removing organisms from air, and with filters in the ventilation system and that. But also they're moving the air around all the time, which you have to realize. Not only the human activity doing that too, but humans, generate, aerosols too, talking, coughing, sneezing. Actually, just putting on clothes, microorganisms as you walk, microorganisms are coming off your clothes, for example. So it's just not sneezing and coughing. But other things too, like washing laundry, doing the laundry. We follow people doing the laundry, sorting the laundry, taking it out of a hamper, putting it in a washing machine, and those actually create aerosols. Particularly handling clothing and clothing material, you generate more aerosols than you might realize. And of course, toilet flushing, which I talked previously about in another webinar, sweeping, vacuuming, all of these activities have to be thought out as potential ways organisms can be resuspended in the air all the time. Any type of human activity will do this. So airborne transmission of it, it depends a lot on the organism, how long it might survive in the air. Some organisms survive very well in the aerosol state, others do not. What size of droplet? What is it suspended in? Is it suspended in a mucus? Is it suspended in from a surface like water? Or how much organic matter is in that surface? Because that will determine how well the virus or bacteria may survive in the environment in that. So there's very, very specific host factors. In the host activity, what's their inhalation rate? How much are they inhaling? What activity are they involved in? What's their age? What's the host susceptibility? Of course, that plays a role too. So there are a lot of factors involved in this. And re-aerosolization of particles, I just want to talk about, can occur from surfaces and settling as surfaces. Now, large particles usually settle within about 5 to 6 minutes on surfaces, but small droplets, it may take even days to hours to settle on a surface. The smaller the particle, which we call aerosolized particle, the longer it will just stay suspended in the air and in that environment that you're looking at. So droplet size makes a difference. But I want to point out both of these, whether they're small droplets or large droplets, will contaminate surfaces and fomites. And now resuspension, we did a lot of studies trying to quantify resuspension. Using a bacterial virus, MS2, doesn't affect human beings, and you can use it as a tracer for other viruses. It's the same shape and size of norovirus and rhinoviruses. So that's one of the reasons we like to use it. It's non-infectious to humans, and it has a survival very similar to these two viruses in the environment too. And we use it in many studies, which I'll talk about, homes, hospitals, offices, to look at how human activity is involved in the transmission of viruses in the indoor environment. And we've contaminated many different surfaces, wood, flooring, cotton, just to see what these different surfaces roles would play in the resuspension and movement of viruses. And we collect settle plates to look at resuspension, basically petri dishes with agar media that we can collect them and determine what types of human activity may cause the resuspension of these viruses. Just to give you an idea, I want to talk about shoes a little bit. I've always found shoes interesting. If you test your average shoe, it will contain about 95% will contain coliform bacteria like Enterobacter, Klebsiella, and about 1/3 of them will contain E. coli on the bottom of the shoes. Where do they come from all the time? Well, restroom floors always have E. coli and coliform bacteria on them. And of course, you may be walking more where dogs walk the last hour or two, but you'd be amazed. Every shoe we've tested that you wear on a general in the house, out of the house, will have coliform and E. coli on the bottom of the shoes. We're amazed that they seem to survive a fairly long time, even days on the bottom of shoes, probably because you have mobile cafeterias on the bottom of your shoes. If you look at your shoes, take a look at it. If you groove shoeing, you'll see pieces of debris and food. Apparently, microbacteria are quite resistant to surviving there. It was maybe a source of food, but we've been amazed. What you see here is we asked somebody to walk through fluorescent dust on a floor, and to see how the shoes movement. To give you an example of what you're putting down on the floor and what you're touching all the time. And so what we did is we had people walk through a segment of floor about 1 foot wide, just put a foot down with bacteria and viruses on the floor. I think we used E. coli in this case, and 10 to the 5 or about 100,000 seemed reasonable. But the virus, we put 10 to the 7. That if you look at somebody with norovirus with vomit, that's about a drop landing on the floor, contain 10 to the 7 noroviruses, because when you throw up, you can throw up 10 to the 8 to 10 to the 9 noroviruses on the floor. And we just wanted to see how they spread. Bacteria seem to come off more on random to us than the viruses, but the viruses, it was amazing how many viruses just walking through on the floor with that many. You picked them in your shoe and kept spreading them as you walked all the time. So really, your shoes, you're spreading these organisms around all the time, just in normal walking activities in that. So what we did was to look at how far, if you walked on the floor with viruses, we put settle plates at different positions, at different heights above the floor. And we used the MS2 on the floor, had a person walk through a segment with MS2 and just saw what happened, how much went into the air, how high did it go, and how far away from the source did it actually go. We were quite amazed that when we looked at the air, how high it went vertically, they travel almost 6 feet into the air. So basically it reached inhalation height for most people, and certainly children in that. The other conclusion is, if you look at the bottom area here, dust made a difference. And I think that's why cleaning floors becomes so important. The amount of virus resuspended increased 10 to 100-fold when there was dust on the floor vertically into the air. So dust makes a big difference. Those blue bars are the dust, and you can see how far it went with the dust. So dust plays a major role in making microorganisms mobile, we actually learned. This is after walking on a carpet. I'm sorry, I didn't explain that too, but carpeting is really quite interesting. Look, this is horizontal, how far after walking on a carpet with MS2 viruses on it. It was amazing. It spread horizontally almost 8 feet from the source. It just settled out. It went into the air, resuspended, and it settled out on the surface 8 feet away. So really, you really create a large aerosol by walking on this, or dust aerosol if you want. Dust is making a big difference here and spreading around those surfaces quite a ways. The other thing was vacuum cleaners. We wanted to look at vacuuming. And basically, I like to call these meals on wheels for bacteria because in looking at the brushes, we found that in homes and brushes, we looked at our facilities here. E. coli was detected on 50% of the brushes, which really surprised us. And when we started looking in the bags, we could find E. coli and salmonella. And we found, and others have found that salmonella E. coli can grow on the material you're picking up from the vacuum cleaner. People don't realize you're concentrating food particles in there. You vacuum, put your vacuum cleaner away. Well, these organisms can grow in there. And we actually had people empty reusable vacuum cleaner holding where they hold the dust inside, and you create a great aerosol when you try to empty a reusable vacuum containing hole. So really, it's always better to use a sealable vacuum cleaning bag and throw it away. You open it up, you're creating a great aerosol of E. coli and salmonella we found out in the immediate vicinity in that. But so vacuum cleaners are another source where you're picking up material, like say on the brushes and that, and then you could be spreading it around. Um, so we did some work on vacuum cleaners where we contaminated sites, those green dots you see here, with MS2. We did wooden floors and we did carpeting too, again with the vacuum cleaners this time. And then we looked, of course, at different distances with settling plates and different heights. We wanted to see what a vacuum cleaner do. One of the reasons for doing a vacuum cleaner, it's been associated with two outbreaks of noroviruses in hotels where they hoteled an area that was contaminated, they thought was clean with a vacuum cleaner. They put it away, the vacuum cleaner, and then they took them out several days later or a week later, one case, and they caused another outbreak of noroviruses. And it was believed because they resuspended the viruses that was in the carpeting or the vacuum cleaner. They weren't sure. But again, we wanted to really see what a vacuum cleaner had done. This is another example showing that where we put it and the heights we're looking at. Does it really get to a breathing height range? Oh yeah, good. And of course we found, boy, the vacuum cleaner just everything got contaminated at very high when dust was present. We looked at dust, even without dust. You would still get a fairly good height of vacuum cleaning. Vacuums, if you look at that, the number with the dust, it just was all the same. That level of virus is about 10 to the 4, 10 to the 5 almost, was almost all the same. The vacuum cleaner with dust really shot the organisms up into the air. Less, of course, without the dust too. And the horizontal distribution was incredible with a vacuum cleaner. Of course, we looked at different distances from it and really contaminated the entire area around it. The vacuum cleaner, I think, largely because it does such a great job of resuspending dust that it really scatters. I mean, anybody that's vacuum cleaning, I would not be too close to them for what we can see. But I think the point here is that it was contaminating other surfaces in a large area around wherever the vacuum cleaning was being done. The other thing we wanted to do, other people have looked at this too, is to put MS2 on a drape. We suspended it between two ladders and we contaminated one of the areas with the MS2 virus. And we had people move the drape as if they were closing it or opening it. The viruses was detected at least 5 feet settling out on surfaces from it, and 6. I mean, so in the whole area around it actually was very well contaminated. The person moving the actual drape was contaminated. Besides his hands, of course, all his clothing was too, because the moving the drape re-aerosolized it and contaminated him. His shirts and his pants were actually also contaminated just by moving a contaminated drape. The other thing we did in another study is we put the viruses, the MS2, in couches and chairs and had people sit in it. And it's like a microbial whoopee cushion. It just instantly throws everything in the air. If you have a virus in a couch material, you get it all over your clothing. You get it on your hands. You get it on your nose. You can inhale it. It's a great way to suspend microorganisms. Even a vinyl chair will suspend it to some extent if you do it. We actually put vaccine strain of influenza virus in couches, and it survived for more than 24 hours in the couch, which really surprises too, even considering how dry the couch was. But any type of sitting activity, we've done this in different types of material, and that makes a big difference in couch material. I should point out there, couches have been involved in outbreaks of cloth material of MRSA in first responders fire stations. It was shown to be a risk. They actually had to go to vinyl surfaces, which they could disinfect because it's very difficult to disinfect a soft surface like a couch. The other thing is to realize that mobile devices play a role, and it's not only about aerosols necessarily, but mobile devices. Other people have shown like mobile devices like chair, bedding materials, mobile phones, wheelchairs can be involved in the movement and circulation of viruses in an environment. Just to give you an idea from some work on the movement of a hospital chair within an environment and how they move. Was a pattern was done was how things are moving around in a wheelchair in a hospital situation. So there's a lot of movement of the activity of where they move around at sites, and each of those could, and others have shown this can be a source for moving viruses around a facility. Any type of mobile device like a wheelchair or wheels pick up things and spread them around. Wheels will re-aerosol microorganisms in that. So again, it's an emphasis that we're always dealing with a rather dynamic situation. One of the things I want to show is what your fingers do when you touch surfaces. We did some work on coronavirus 229E, the one that causes respiratory diseases involved in the common cold activities in that. So the surfaces make a difference. Now it varies with the virus and the bacteria. It's the thing that surprised us. We didn't get much transfer with stainless steel to people's fingers. But it was much different when we looked at porcelain. Now this is an envelope virus. It may have made a difference. When we did this with non-envelope viruses, stainless steel was the highest in the amount of transfer on a surface. So it does vary with the surface you're touching. One of the other areas that I want to talk about is, so you have all this data, so the viruses, bacteria move around. So what are you doing with this kind of data and the movement of the bacteria? What we do is we do risk analysis, which is quantitative microbial risk analysis, QMRA. We use that because of it's for a lot of reasons. One, we can eliminate a lot of confounding factors versus the epidemiological. The precision is fairly good. It's been ground truth against outbreaks by fomites, water, and foods. Small number of individuals, or you don't need any all. You can actually do it mathematically if you have data on exposure. Short observation times generally on activity can determine what's achievable in terms of risk reduction very quickly because you can get data within a few days or weeks actually. Can determine the importance of specific routes of transmission because we're doing tracer work, and it's a fraction of the cost of epidemiologically and time-wise. So that's how we like to interpret and use this data I've just been showing you about. Quantitative microbial risk analysis, in case you're not familiar with it, what it is, you identify a hazard, like you're looking for a particular organism like a coronavirus or a norovirus we generally use for a lot of our work, or E. coli. So you pick an organism and then you do an exposure assessment. What's your exposure to? You can do that by sampling surfaces, or like we did, do a tracer study. Put a number of organisms on a surface and determine where they end up. And if somebody touches that surface where they end up, what's their risk? And then dose response. There's a lot of dose response data, like for norovirus, there's dose response data. For E. coli, there's dose response data. And so a lot of this is online and it's available through a QMRA wiki, which provides you with that information. Then you characterize the risk. What's your risk? What's your probability of getting infected and harmed? And then you can use that kind of insight for a risk management. What do you think is really going to work in that without doing a large epidemiological study? Now, quantitative microbial risk assessment, just to go over that quickly, you look at the concentration of a virus like we did per square centimeter squared, and then we look at how much often you touch your hands and how much is transferred to your hands, and then how much is transferred through your lip or mucous membrane. To give you a rough idea, most organisms from your finger to your hand, as I've shown, vary from any less than 1% to 50%. To your mouth, it runs around 10%. If you touch your nose or mouth, you get about 10% of the organisms on your hands, on your nose or mouth. And then you can do the dose response. You model the dose response. It's fairly easy to do, simple math. And then you look at the probability of infection. What's the probability? Is it a 90% chance? Is it a 10% chance? And of course, we did this with the data I showed you. This is rather complex. But what's your risk of touching and getting norovirus after resuspension, like a vacuum cleaning event and landing on a surface? What's your idea? We did this with both dust and tripartite organic matter, assuming that we would assume the organisms are going to be resuspended like in mucus or saliva. But let me just go on the left end is your probability of getting infected. Like 1 times 10 to the 6 is 1 in a million risk per event. Now, that's often taken as the target is what the object of any kind of intervention should achieve is get your risk down to less than 1 in a million, because EPA used that risk for drinking water. In other words, we're supposed to treat drinking water in the United States to reduce your risk to 1 in a million per day. And so that's kind of often taken as the objective. And as you can see, as the organisms on the bottom here go up, your risk increases. So 10 to the 6 is their objective here. And you can see what a carpeting, and looking at your resuspension by vacuum cleaning and going on a surface that you would touch, your risk remains above 10 to the 6 on the areas that are getting contaminated near that vacuum cleaning event. For it, you see much less probability with when you're looking at walking on I'm looking vacuum on a hard floor, and of course then your risk are less when you're looking at a carpeting walking on, because less resuspension in that we're looking at, and these are the distances that you're looking at too. But what it shows us, if we're looking at the 10 to the 6 as our guideline, vacuuming it seems to be a higher risk with carpeting, but there's still risks that exist above the 10 to the 6 level for it. Let me give you the idea of so we believe that the risk could be significant. One of the other questions was, well, how fast does a microbe move in an indoor environment? You might be quite surprised. We did push plates, doorknobs, elevator buttons. We put viruses on it. We put them in coffee break rooms. We add a bacterial virus, like in this case, I'm going to give you an example, to an office building with a push plate. And we collected samples in the facility on people's hands and fomites after different hours after the push plate. This was the entrance to the building. The assumption here is that individuals going to enter. First place you find this virus is the coffee break room, because that's the first place I think everybody goes in the morning when they go to work. But we've noticed this when we looked for hospital-acquired infection-associated bacteria. The break room in nursing homes, offices, in hospitals, the break rooms, the nurse break rooms, is give you an example, is the most contaminated with HAI bacteria because it's not clean and disinfected on the right place. So people are spending both, transferring both gossip and germs in the same place. But so it pays to be the first one to the coffee cup in the morning, a coffee dispenser. But we did as an intervention in this study too. We looked at the spread of the organisms, and we did an intervention with the MS2, again putting it on the doorknob. And about half the employees in this facility of 80 agreed to participate in this. So we said, well, let's see what that's going to do. And if you start looking at the impact of the intervention over time, after 4 hours and after 7 hours, the percentage of employees' contaminated hands was about 52%. Contaminated fomites was 56%. And this is the whole facility. And after 7 hours, it stayed about the same. So really within 4 hours after putting that virus tracer on the entrance to this large building, almost 52% of all the surfaces you touched would have this virus on it. Uh, it's quite amazing. We were amazed how these viruses could actually spread. Now, with the intervention, where we provided people with the hand sanitizer station, we provided disinfecting wipes to people so they could wipe their desk if they wanted, and we gave them some training on how often to use it. And we showed we could reduce the amount of contamination in the facility by just providing a hand sanitizer station and giving them disinfectant wipes. But that gives you an example how you can easily get an idea how an intervention can reduce the amount of spread of a virus or organism. Very simple, very inexpensive to do. And then you can take this data and use it in risk analysis to actually look at how much illness you might have reduced by doing this in a facility, and this gives you an idea of how much illness you reduce. The risk of infection is over here. One is like 100% chance. And so what we did is we looked at, well, the risk of infection here, let's say was about 40, 40%, let's say. And we looked at the reduction of rotavirus, influenza, norovirus, and reovirus, and they were all reduced by quite a bit. And the significance of this study was quite high because of the intervention. So they said by providing just a disinfection wipe and a hand sanitizer station, we could reduce the probability of infection by more than 70% in all of these and that. So it's a simple way of looking at, this was an effective intervention. And it didn't take a lot of time or cost to do this if you do this type of analysis. Can I have the next slide? This is a percent transfer of putting bacteria on looking at shoes and disinfecting that Dr. Donsky did some years ago, looking at different bacteria on the shoes and ways of disinfect them, transfer from the shoes to the floor. He was looking at using a UV light system for disinfecting the shoes because, as I've already pointed out, shoes are a great way to move microorganisms around in a facility and that. And basically, that's what he was able to show here. Interesting, there's a variability of how they spread from one organism to another. And the resistance, I think, this UV light to some extent on the bottom of shoes made a difference here too. So really, what do you do about shoes? Well, Dr. Donsey gave an option here if you could use UV light C to disinfect shoes in that. So that's one of the options you can have for disinfecting shoes. People have tried other options like antimicrobial mats, for example, wearing shoes that can be washed on a regular basis. Actually, those turned out to be quite well. We looked at shoes that you could actually wash and reduce the number of organisms on a surface, and those can quite well. They actually are shoes that can do that. Or there are other certain types of shoes that pick up less microorganisms that are sold today. These are usually, most people have hard rubber shoes these days, but if you go to soft textured shoes, you can actually reduce the survival of organisms on your shoes and your ability to pick them up. It depends on the type of shoe you're actually wearing. So there is some options you have to deal with that too. I want to give the examples of various studies we have done over the years on virus tracer studies and hygiene and virus movement through facilities. In that office building one here I highlighted, where we use hand sanitizers, disinfecting wipe, and pretty much we added all those organisms I talked about. We could reduce it by 77% or more based on QMRA. In other words, the risk of infection. I should point out, this is risk of infection, not disease, because the US EPA's regulation for drinking water has to do with infection. Why infection and not illness? Because it's difficult to predict the probability of somebody developing a serious illness from an infection. Many people will become asymptomatic, and it depends on the organism. Some people will become more clinically ill than others because of their immune status and that. So basically, what everybody tries to do when they do this risk analysis is do it risk of infection rather than risk of illness. And in hotel and conference rooms, we actually did a study where we in a hotel that was having a conference on it. We put the virus in one of the hotel rooms on the countertop in the restroom. And within the phone within the hotel too, a room, and the maid succeeded in spreading that virus from that one hotel room to at least 4 other hotel rooms that they cleaned in a row. It was amazed how mobile the cleaning staff can make, certainly in a hotel, of a virus spread in that. And then we did an intervention with them. We talked to them about the cleaning procedures, the disinfection, and provide them with hand sanitizers and disinfectants to use during the day. And we reduced the spread in contamination surfaces by 87% in this case. So it was more of a way of giving them the right products to use, a hand sanitizer they could use. And it made a really big difference in how bad. So really, when you hear somebody sneezing in the room next to you in a hotel, worry about it, that it might be in your room tomorrow night, from what we could tell on it. But nursing homes, we've done a number of studies really looking at hand sanitizers, and it made a big difference. We could reduce the spread of the viruses by the nursing staff in the nursing homes by 99%. Again, one of the things, it was interesting, the most heavily contaminated area was the break room for the nurses. And so we made sure there was hand sanitizer and disinfecting wipes in the break room to make sure they had them, really to help sanitize the own facility that they were working in. And in homes, we've done a lot of work with hand sanitizers in homes and home activity, and it makes a big difference, hand sanitizers in the home. The other thing that we looked at was the kitchen sponge in cleaning tools. Cleaning tools can be ways of spreading organisms in the home. And this applies to reusable cleaning tools like mops, for example. Wet mops would be a classic example, or cleaning cloths. I mean, most healthcare facilities have rules about cleaning cloths and reusing them in that. But if they're not reused, there are really issue, particularly in kitchen areas. And why do I mention kitchen areas? Because break rooms often have areas to prepare food. That's a kitchen area. When we went in to look at a lot of those break rooms, they had sponges for the staff to use in that. That's why I kind of bring up that relevance to that. But we found that by disinfecting the sponges, we could reduce the probability of finding salmonella in a sponge by 99%. There's a lot of food in the sponge. You have to realize when you're cleaning up a surface, you're putting organic matter, which microorganisms can use, and they grow in the sponges, by the way. I don't know people, if you realize, like recent work indicates a major source of exposure to antibiotic-resistant bacteria in household is the kitchen, is the major source for urinary tract infection related bacteria. And I think it has a lot to do with the ability of these organisms coming in on the food supply and then being able to grow in the sponges. In studies we did, we could squeeze out tens of thousands of HAI bacteria out of a kitchen sponge in the average home. So they found a great, happy place to live. So sponges and cleaning tools should always be looked at as mobile devices for microorganisms actually moving around all the time. We also looked at EMS responders in that, because there was an association with couches and then being affected with MRSA. But we also, a group that at our university was looking at reduced virus spread in the vehicles used to transport patients in that. And it was more of a challenge in there because of the speed and activity going on. And so sometimes it can be challenging depending on what's taking place, the amount of activities in a facility and that. But we could only reduce the probability of infection by 16% in it. I think largely because there's so much activity going on, so many surfaces being touched in an emergency and that, and in a situation. So it becomes much more of a challenging event sometimes of controlling it and then decontaminating surfaces and hands and what kind of other sources they use. So let me go over some of these conclusions. And I think one of the things is the movement of pathogens in a built environment is a really very dynamic situation. It's not a static situation. And I think one of the things we want to bring out is that it's all the activities. If something lands on a surface of fomite, it still has the ability to be resuspended into the air and inhaled. So there's a dynamic relationship with what's on the fomite surface and what's in the air at any time, and that because of human activity going on. So you really shouldn't look at organisms on surfaces as not being really related to the probability of getting a respiratory disease like influenza, coronaviruses. There's a dynamic relationship here between what's on the surface and what's in the air you're inhaling at any time in that. So I think some people have really pointed out that, well, aerosol prevention is really the whole focal point, but fomites also play a role in what's in the air you're breathing at any one time, and it should not be neglected, even though the principal route of transmission by an organism may be an aerosol route. What's on the surface plays a role. And we've seen in the data I've shown here and other work that we've done, the disinfecting surfaces in a facility reduces the amount of these organisms in the air. And controlling the dust and dirt does the same thing too, because they play a role in the transport of these microorganisms in these environments. I think movement of any activity, really in modeling the ability of trying to reduce the amount of aerosol transmission of viruses in a facility, it gets more challenging to get the kind of reductions you get with fomites. For example, in an air, because of human activity, people are talking, moving around, touching surfaces, controlling what's in the air becomes much more challenging, reducing your risks greater than 40 or 50% by an aerosol route transmission with interventions that may involve airflow, controlling it, enhancing airflow through high vac systems in there. It still becomes a challenge because the organisms still have to move to that vent or other surface in that before they're eliminated from the facility. So it creates more of an opportunity. So controlling disease spread in terms of risk of infection is much more difficult in just in organisms of air than it is on fomites, which is much easier to control. I think a lot of things have been pointed out before of their potential role in transmission, like cell phones and shoes and that. But all of these play a role. So really makes infection control much more challenging than most people realize. But interventions we feel using quantitative microbial risk assessment or not, we can get an idea of what's working, what's the reduced potential for risk of transmission by a route by doing simple intervention studies for viruses and transmission, to give you an example, or bacteria. We've done these studies with bacteria too of it, but it gives you an idea of it. I always look at the challenge here in the healthcare environment because of the activity, and many times many things are done rather quickly and in an emergency situation, so it's difficult to always control all these activities all the time. But I believe in the future, using QMRA and intervention we talked about, we'll have a much more quantitative idea. Really, our long-term future is to try to come up with some type of metrics that we can quantify in this way to say, okay, by doing X, like using certain types of shoes to reduce the pickup and survival of bacteria or viruses, then we can reduce the risk of infection at a facility by X amount. And then by contaminating these surfaces, but we can get a real idea of a number, and so we can get an idea. Okay, this gives us a 50% reduction by this route, another 50% by this route. So our total metrics indicates we can reduce it by some type of value that we can actually look at and quantify. I think the long-term goal of this work and any work in the indoor environment now is to try to quantify things better so we can develop some type of format or app situation where you can put in what you're doing and get an idea of it. And if you made a change, what would be your probability of reducing infection by a certain route? Um, to develop that type of metrics. I'm hoping that in the future that will be our goal with the type of data that we've been generating. Thanks a lot for your time. I'd be happy to answer any questions.
Thank you so much. That was very interesting and very thought-provoking. I don't see any questions in the chat yet, but if anyone has any, please do write them in the chat. In the meantime, I had a few questions. So because when we're talking about viruses like influenza that are usually thought of being transmitted more through aerosol, how come when you just had an intervention on surfaces and hands that you got an 80% reduction in infection? Was that only because there were no people producing aerosol in the space and that was sort of calculated in that way? Or
Yeah.
Okay.
Oh, no. So that was a good question. Most of the work I showed was to do with transmission by your hands rather than the aerosol route. In other words, touching a surface, getting it on your finger, your hand, bringing to your mouth, nose, or eyes. When we did the aerosol work, which I didn't show, of the probability to do that, we could only reduce the risk by about 50%, 40 to 50%. Because when you resuspend something in the air, it gets more challenging because of the movement of the people, of it. It's hard to control, like if you walk on a surface where you can inhale that as it rises into the air before it goes out of a vent. Like say you have a high vac system with high airflow. Well, it's got to get to that facility, that event before it does it. And it's going to pass you or somebody else to get there. So it really becomes more challenging. And I think more need for more interventions, for example, like some people have looked at 220 nanometer, like we really need to find ways, or there's aerosol spray disinfectants now that can be used in facilities of dealing with how to kill organisms in the air. I think the real challenge from what we saw was we have to have something in the air that can kill the organisms, because doing airflow in that is not going to do it. And when people are moving around and there's several people in a facility, we did the risk analysis. It turned out to be much more challenging to do that because of all the resuspension and getting it to the airflow device, or a device that would, for example, like a device placed in a room that air would flow and it could disinfect, because the air has got to move there first.
Thank you. My other question is that we know that the overuse of disinfectants has an impact on the prevalence of MDROs in the environmental microbiome. So there's lots of different schools of thought about how much disinfectant we actually want to put into a space. What are your thoughts on that?
Yeah, that's a good question too. How much we use that's one of the things we're looking at too, is how much do you really need and how much you need on these surfaces. I think the future is going to be a combination of things. We've been looking at, in terms of disinfecting surfaces, I think antimicrobial surfaces, if they can, and we've looked at those, and they actually persistent disinfectant surfaces, some people call that may be one option for in combination maybe with regular cleaning and other interventions like maybe 220 nanometer light, persistent disinfectants. I think I think we have to have a combination. I think we've always looked at, let's control a organism on a surface by coming in and cleaning and disinfecting once a day. Well, of course, we know it gets recontaminated. So maybe a persistent disinfectant on top of that is what we need. So we don't over disinfect those surfaces all the time, or perhaps like 220 nanometer light in a facility may be another option, or other types of aerosol intervention. So we don't over disinfect in that. I think I think one of the issues is trying to do a combination. I think we've always tried one strategy before, like disinfect the surface, maybe add the UV light, but we need a combination. We need to know how these work synergistically in together. I think there are options where we can create situations where the use and variation of product can act synergistic, not just by themselves independently, but act together to create a better situation where there's synergism so we can reduce both the amount of disinfectant and other interventions. So I think we should start looking for synergism.
Mm-hmm. Thank you so much. And then I have one comment from Dr. William Sawyer, who sent in a comment by email, who said that he would suggest that the summary should be: do not touch the T-zone, facial, mucous membranes, hand sanitizer, and surface wipes. Pass it on.
Yeah, that's good. That's great from what we see. One thing I should add, the combination is really good. We've done, hand washing. The recommended procedure is really great for moving bacteria, of course, which are the primary concern in the healthcare situation. But they don't do as good a job at viruses, we found. So hand washing and hand sanitizer seem to be necessary to remove the risk, at least from norovirus, because they did not remove the norovirus below the level that we wanted to without a hand sanitizer. Now, that's norovirus. Now, other viruses like influenza, coronavirus, for
easy.
Soap will kill it because it's an envelope virus, but non-envelope viruses may be more of a challenge in that. I'd like to see people really develop some type of residual for hand sanitizers, at least for the respiratory viruses, because that's easier to deal with. Just as we have developed persistent disinfectants for surface disinfection in that too. So I think there's a lot of challenges, but I think a lot of great opportunities.
No, there's lots of research being done in that area also for hand sanitizer. So it'll be interesting to see what comes out of that. Very good. I don't see any more questions, so I'll move on to just use this time to talk a tiny bit about Clean Hospitals. So the Clean Hospitals group, which I'm president of, is a group and a network with the goal to break down the silos between the public and private spheres in infection prevention, and we concentrate on environmental hygiene and on hand hygiene. We have Clean Hospitals Day every year, so it'll be on the 20th of October, 2026. And if any industries or healthcare facilities are interested in joining, please don't hesitate to reach out, and we'd love to speak with you. And then for the next upcoming Weber teleclasses, there's only one more for this year because the one from the 16th was postponed to 2026. So that'll be on September 18th, Empowering Patients to Prevent Healthcare-Associated Infections with Dr. Curtis Donsky from the US. And I'm sure that'll be a very good one as well. And it's the 25th anniversary of teleclasses. So thank you so much for joining, and it's been a pleasure. And thanks again to all of our patron sponsors. So that's Diversey, a Solenis company, Virox, and Gamma Healthcare. And thank you to Paul for inviting us to be here.